Hi, and welcome to the webinar about all ceramic dental implants. I'm Dr. Dan Hagi from Thornhill, Ontario, which is the city above Toronto. And what we're going to do today is we're going to explore an emerging trend in implantology. And we're going to explore how I use it in my practice and the advantages and disadvantages of this material. So we're going to start off with a little bit about myself. Like I said, I practice in Thornhill, which is the city above Toronto. We focus on aesthetic, implant, and metal-free rehabilitation. I've been trained by Dr. Carl Misch in both the surgical and prosthetic parts of implant dentistry. I'm an associate fellow of the American Academy of Implant Dentistry and a fellow of the ICOI. I was introduced to ceramic dental implants around 2011. After having placed and seen the successes or the initial successes with titanium implants, a few years after, I started realizing that not everything that succeeds initially succeeds long term. And through these failures and complications, what have you, I realized that there are problems with what we're doing. We have solutions to a lot of these problems, and we struggle with a lot of these things. But there are issues with the use of a two-piece titanium implant. And I was open to seeing what else is out there. And I realized that there was a whole group of practices, a whole group of researchers that have been focusing on ceramic dental implants since the early 90s. And it hasn't come to North America at all. And that's when I took it upon myself to explore this. I've been placing these implants for the past 4 years. And at this point, I'm even helping in the training and education, trying to spread the word about these materials and the problems that they solve, and this is where we are today. So my objectives for today are going to be to explore what are the design characteristics of successful dental implants, what is this material zirconia, and why use it as an implant? What are the advantages, the indications for the use of these implants, and then we're going to review some clinical cases that I have behind me. This picture is a great picture because prosthetically, I always envision if a patient comes in and has a tooth that looks like this, not an implant, but a tooth, we were all trained that this is something that's non-restorable. But if the patient walks in looking like this with an implant, we have various tools in our toolbox to put a tooth on there, but we're thinking in a way that that is not how we were trained with teeth. What I think the ideal solution and what I'm going to present to you today is a solution that is a tooth replacement rather than an implantation of a foreign body that gets restored. And that's the essence of this idea. This is what we need to wrap our minds around, is that we're looking at a completely new paradigm of replacing a tooth. Anytime I talk about the ceramic dental implants, I always get 3 questions. Once I answer these 3 questions, there's a whole slew of others. But these are the main 3 questions. I'm going to answer them right off the bat. This case was done by Dr. Vasil and Shimantov in New York, and exemplifies this use of these implants in a case that if we tried doing this with titanium, it would be extremely difficult to attain an aesthetic result like that with individual adjacent implants. So this is sort of the pinnacle of what can be done with this material, and the answer to these 3 questions are as follows. Zirconia osseointegrate. So we're going to explore some of the research behind this. It doesn't break easily. It's known in orthopedic surgery and every other discipline as ceramic steel. It has physical characteristics that are even stronger than the titanium metal. And everything in nature tends to be radioactive, but it is not a concern for us as far as the material goes and using it in the oral cavity. And this is where the paradigm shift occurs. So when we look at success in implant dentistry, everything thus far in the literature has tried to measure implant survival. The original work that everybody cites, going back to Bernard-Marc's days, the 40-plus years of research, have always looked at, does the implant survive in the long term? It's only in recent years that we started looking at other factors, such as hard tissue stability, soft tissue stability, patient satisfaction to some degree. Are they happy with the tooth that they have? Does the recession bother them? Do the black lines around the implants bother them? And then we have another factor which is important to some of us, which is our pride in what we do. There are amazing things that we could do with this class of materials that would take a lot of work, a lot of effort, and sometimes for none with the other things that we're used to. In 2003, Jokstad came up with a study where he correlated design characteristics of dental implants and associated them with clinical outcomes. And he had essentially 7 clinical outcomes that he was exploring: osseointegration, mechanical failure, what happens to the tissues around the implants, the aesthetics, the ease of placement. And he correlated those to certain design characteristics about the implant. And those design characteristics included the geometry of the implant body, the material of the implant, and at that time focusing in on different grades of titanium, the implant dimensions, the abutment interfaces. This list basically comes down to say that success in implant dentistry, as far as the design characteristics of the implant, depends on implant body geometry. And we all accept that today we're using tapered cylinders to replace teeth. The blade implants, the hollow cylinders, all these have been there in the past, but are not much used today. The surface topography of the implant needs to be roughened, and we know that a rough surface integrates and accepts the bone much better. The implant dimensions are important because we know a bigger implant has more surface area and thus has better stability. The implant and abutment interface geometry has been, again, the focus of a lot of research recently, especially from the standpoint that that abutment interface affects the stability of the bone and the stability of the tissues. The abutment material, again, we've seen the phase changing from gold to titanium to aluminum oxides and now to zirconia oxides. These abutment materials are important in terms of soft tissue health and the final aesthetics of our cases as well in situations where we have thinner tissue. And finally, we had implant material. And the implant material that Jokstad was talking about was comparing different grades of titanium, grade 1, grade 2, most common now grade 4. Each one has different physical properties and allows us to have better success, less mechanical failures. What I'm going to focus on, because everything else on this list is essentially the same across the board. Everything's a cylinder. Everything needs to be as big as you can get it. Everything needs to be rough. But the implant material is the one thing that we were limited to titanium. And today we have something else. So we're going to explore each of these clinical outcomes and explore how it relates to the material that we're discussing. Zirconia has been known to osseointegrate since studies that were done in the early 90s. Akagawa's group in Japan, Gallert's group in Germany, there have been studies that came out showing the same tendency for the material to integrate as titanium. With a study by Gallert in 2007, which compared SLA titanium to smooth zirconia, the bone-to-implant contact that he was showing was very similar at the end of a 12-week healing period. There were differences initially as things were healing, and Gallert's comment, that had to do a lot with the surface of the zirconia implant, because at that time it was just a sintered implant. Further studies that we're going to explore are going to show differences with a roughened surface. The titanium BIC that Romanos published in 2005, and it's accepted in a lot of the literature, is that a BIC somewhere between 60 and 80% is what we see with nearly all designs of titanium implants, including Nobel's, the Ankylos, and the 3i. The CeraRoot implant, which is the zirconia implant that I've been placing, in a more recent study, showed PIC of 78% at 3 months post-surgery. And here we have a slide showing the intimate contact between bone and the surface of that implant. As well, we got some HD stained slides showing the intimate contact of bone and the bone cells against the acid-etched surface of the CeraRoot implant. And this is what we want to see. This is the evidence of integration. Clinically, the implant integrated. All we know is that we have rigid fixation. See a slide, an H&E slide of the intimate contact between the bone and the implant surface. And here again, we see the evidence of that roughened acid-etched surface, which promotes the osseointegration. And we see the bone cells and the intimate contact against the implant surface, which is what we want to see in integration. Now, clinically, osseointegration is almost meaningless because it's something that Mark described as a phenomenon that's visible under the light microscope. What we want in the mouth is rigid fixation that is maintained long term, and that's something that we definitely get with zirconia. The next clinical outcome that was explored was mechanical failure of the dental implant, or how strong is this material. Zirconia in the periodic table is heavier than titanium. It's a common transition metal, and it's a strong metal. Now I say metal. Everybody says that zirconia is still a metal. Titanium is a metal. Zirconia is a metal. All these materials have very common physical properties in their metallic form. However, once we obtain that raw material, which usually comes from sand or batolite, that gets refined and turns either into the zirconium metal, which is one form of that element, or to the oxide, which is zirconia oxide, and that bears absolutely no metallic properties. So comparing the physical properties of these two materials, one can very clearly see, now I'm not a chemist, but one can clearly see that one of them definitely has the properties of the metal. It's gray in color, it's held together by metallic bonds, it's malleable, it wears, it conducts electricity and heat, it oxidizes easily, and it's mostly used in nuclear reactors. That's the metal zirconia. The ceramic zirconia, which is the technical ceramics that we're using in dentistry, is a white ceramic held by covalent bonds. It's extremely strong. It tends to be fragile. It's wear resistant. It's an insulant of electricity and heat, and it doesn't oxidize. So there is no metal in these zirconia implants. It's completely a ceramic. Now, this ceramic is fragile, as you saw, as are a lot of the ceramics. And zirconia on its own is as well. There's a process where yttria stabilizes this structure. And this is the beauty of what yttria stabilized zirconia is and how it's used for all these high-stress applications. Now, again, I stress the fact that I'm not a chemist, but there's a complicated process that takes the zircon sand through chlorination and precipitation steps and creates this yttria stabilized tetragonal zirconia. When zirconia at room temperature is heated, the phase change is accompanied by a volume change, and that volume change with this material, because of that phase change from tetragonal to monoclinic, has a different volumetric change on cooling and on heating, which is why if it doesn't get stabilized, the material is unstable at room temperature and it cracks. That's what the role of yttria is. It is to stabilize the structure in that phase at room temperature, which gives us the ability to have strength in the material as well as resist crack propagation. As a crack inside that material advances, the tetragonal structure actually shifts phases and becomes more monoclinic, which compresses against the crack and it resists it. That's why the material is so tough and hard, and when we use it as a crown, we have almost crowns that are indestructible and cannot break. And the same thing goes with these implants. They're extremely, extremely strong materials. Flexural strengths of 900 to 1200 megapascals, extremely hard in terms of Vickers, and the Wild-Bull modulus, which is a ratio of failure of the material, is extremely high as well. This is unlike the alumina oxides in the past of implants that were tried in the 80s, like the Tubigen implants that would break. This material is much harder, and it has a flexural strength that's much higher than what the alumina had. Completely different classes of materials. In ISO testing, this is the Serra root implant, had some incredible results in terms of strength, static fracture strength of about almost 3,000 newtons, and a dynamic strength of about 2,000. And we're going to compare that now to what happens with titanium. And this is a study that was conducted by Bogan and Mish. They compared the strength of different titanium implants. And if you look at the time, the strongest or the most stress-resistant implant was a 1 millimeter external X with a 5 millimeter platform. And you can see the static failure load and the fatigue failure load of that implant. Now today, most of our implants are internal X's, which are, again, you can see the chart, you can see the weakness of those. If I put up the strength of what the Zirconia was, there is really no doubt about how strong this material is. Fracture of this is really not a concern as long as we're respecting this material. Titanium breaks too. If we have a mini implant, even though it's titanium, we're risking a fracture if we misuse it. A 3 millimeter implant is likely to fracture more than a 5 millimeter platform. And the same thing goes with zirconia. If our implants are too thin, if our bodies are not thick enough, and we're trying to apply it in a molar site on a bruxer, we're running the risk of fracture, and that's realistic. But if the application of the implant is correct, and we're replacing the indicated tooth, fracture does not seem to be an issue with this material. The next clinical outcome, I bunched these together. The mechanical problems with the implant, abutment connection, the peri-implant mucositis, and the marginal bone loss, in my opinion, happens a lot, A, because of stress on the system, which we're mitigating with correct treatment planning and with, again, the correct application of the number and position of these implants. But the other contributing factor that we tend to ignore is the fact that we are dealing with two-piece implants with a connection that is almost always subgingival and it harbors bacteria. The zirconia implant that I place is a one-piece implant. A study by Herman was exploring what happens to the bone and the soft tissue when we compare the one-piece design to the two-piece design. And his study included two groups. In the first group, 3 prototypes, a one-piece implant with a smooth collar and a roughened body. The interface between the two was at osseous level. In the second prototype, in the first group, we had that interface subcrestally. And in the third one, we actually had a two-piece implant with the abutment connected to the implant, the interface between smooth and rough below bone. This was more akin to today's one abutment, one time idea. In the second group, he explored two-piece implants and positioned the rough to smooth interface either crestally, supercrestally, or subcrestally, just trying to vary that position and see what happens to the bone levels. After the healing time, the conclusion was that the least amount of bone remodeling occurred around the one-piece implant, and that the remodeling on that one-piece implant occurred at that interface between smooth and rough. So significantly increased amounts of crestal bone loss around two-piece implants. Biologic width dimensions vary depending on implant design, and that had to do with where that rough to smooth interface was. Biologic width around one-piece implants was more similar to natural teeth, and there was less inflammation around the one-piece implants compared to the two-piece implants. Clearly, though, in dentistry today, we don't use one-piece titanium, at least not commonly, because they're really difficult to restore. We would need to hide the metal to get to an aesthetic outcome, or place these implants so far palatally or lingually they would be really, really impossible to restore. A lot of the companies today try to overcome this problem with the two-piece design, and a lot of the research has come into this. We have platform switching, we have conical connections, we have laser locks, we have micro threads, we have all these things that try to minimize the bone loss, the tissue changes around these implants in the long term. What we get with these ceramic implants is a one-piece design, and we're going to see what this looks like right now. The day of surgery, the implant is placed. The whole surface of the implant is roughened. So from top to bottom, there's only a rough surface. There is no rough to smooth interface on the CERAMIC implants. Now, the advantage of that is that we can place the implant as deep or as shallow as we need to get an aesthetic result. At 7 years, this is what we look like. The prosthetic connection, the only connection is supragingival or equigingival, just like a natural tooth, just like a crown on a natural tooth would be. And we have tissue that supports this complex. There are no subgingival connections for bacteria to adhere into. There is no screw loosening. We have no attachment problems with a one-piece implant. And our gingiva, because of the white color of that implant, is always the same color as natural teeth. And as a result of all this, our soft tissue attachment rivals that of teeth. Now, I'm not saying that there is connective tissue attachment to the actual surface of the zirconia, but there are no probing depths with these implants. The probing is very minimal. It's the attachment that is extremely similar to natural teeth, and it's evidenced by the healthy soft tissue that we almost always see around these implants. Now, of course, keeping these implants clean and keeping the sites clean is extremely important. There's no miracle in implant dentistry that's going to overcome bad hygiene, and tissues get inflamed around these implants as well. If somebody is prone to periodontal disease, we have problems around these implants too, but they are less common and less destructive than what they would be like around titanium. So hygiene is always of utmost important. And then the aesthetics. Everybody believes that that is the most important reason of why we're using zirconia, because it's white. I demonstrated that health of tissue came before the aesthetics and the ease of placement. But at this point, I want to explore a little bit about how beautiful these results can be and how simple the restorative or prosthetic process is. So here we have a failed left central incisor. It was a fracture of the tooth, previously endodontically treated. We have a relatively thick biotype. In this case, the atraumatic extraction of the tooth with the vertical fracture evident. Our socket is curetted. We make sure that everything is nice and clean, and we're ready to begin our osteotomy. We use a drill guide, in this case an Essex appliance that was preformed, and we use a hole at the bottom of that Essex appliance in order to guide our drills, our osteotomy drills, to get proper inclination of that implant. That's our first twist drill in place, perfectly positioned along the incisal edge of the tooth. We're slowly enlarging the osteotomy, of course, and we use a profile drill or a countersink in order to establish the emergence profile of the implant. Unlike titanium implants that are placed at bone level, and then we use the restoration to build the emergence out of the gum, these implants have an emergence profile built into them. And that's the purpose of the countersink, is to prepare the bone for that emergence profile. The implant comes with a silicone carrier, and it's threaded into the osteotomy. Final positioning is done with a torque wrench, and we see here on this slide the final position of the implant with the restorative margin just slightly subgingival. We're going to look at an occlusal view a second, and we're going to see that we have very nice positioning of that implant. We have ample tissue to the facial. We have a little bit of a void around the implant. That was the difference between the size of the tooth and the implant that's going in, much smaller than what we would have seen with a smaller titanium implant. And we can see how the implant in the socket is essentially, when we're looking down on it, crown prep. And we can envision the shape and the contours of the final crown. We use a little bit of BioOS to, in this case, to graft around the voids, and we suture the area with PTFE. That's the immediately post-operative radiograph with the implant in place. And we use a second Essex appliance as a provisional and a protective splint for the implant, so the patient can't load the implant while we're integrating. And we have an aesthetic solution that is away from the gingiva to allow the maximal gingival downgrowth. And this is what the patient goes home with. This is after healing, and we see how the soft tissue migrated coronally, and we have a nice soft tissue profile to start our restorative phase. That's the close-up. Again, this looks like a tooth preparation, be it an aggressive preparation, but it is. Most of these cases do not require preparation of the zirconia abutment. If it is necessary, we use a red diamond with copious water irrigation, and we're able to prepare the abutment. We try to keep that preparation to a minimum. Our protocol is to place the implant ideally, try to avoid preparation. If we can keep most of the bulk of that abutment there, that's our preferred way. We don't want to, because of an inadequately planned surgery, hack away half of that abutment. We need it for retention. It's much like a tooth. If you had a tooth there, you would want to minimize your preparation of that tooth because you don't want to get too close to the nerve, and you don't want to sacrifice tooth structure. The same philosophy, the same thinking is with the zirconia. Once everything has healed, again, the healed radiograph, we're ready to restore. We use either a laser or an electric knife to trough around a little bit of the tissue. We're ready for a pickup impression, and we fabricate the crown. In this case, an Emax crown was cemented in place. I usually cement my cases with Fujisan cement. And this is the final result, and we can see how nice the tissue migrated coronally and how the soft tissue contour was maintained throughout the healing phase. And this is the final radiograph with the crown on. And what I want you to notice is the emergence profile of that tooth, and it's a very wide tooth. you can almost not tell where the implant starts and where the crown starts. I'm sorry, this is not a Limax crown. This happens to be actually a Zirconia crown, which is why you see that white through it. But you can see how continuous that emergence profile is with the tooth. And this is what we look at from the case preoperatively and postoperatively. And we maintain their soft tissue, and we can expect that soft tissue to stay there long term. So what we're really looking at is ideal tooth replacement. And we have predictable osseointegration. We have very minimal mechanical problems attributed to the strength of this material. We have ease of placement and restoration once you're properly trained and go through the learning curve. Simple, predictable aesthetics, and minimal soft tissue loss around the implants. The main systems that are out on the market are summarized in this chart. I have only had experience placing the CeraRoot implants, which is again a one-piece implant. It's the only one that's Health Canada approved. The other main system at this point in time is the Z systems and the Evo, and there are both one and two-piece varieties, and the US has approval for these two. Canada does not at this point. The other systems are few and far between. They're companies that are emerging slowly, and I'm finding that as time goes by, there's more and more companies coming out with their own variation of the zirconia implant, much like has happened with titanium going back 20, 30 years. Interesting to note that Nobel has had a zirconia implant FDA approved since 2007, but it's really never gone to market. And Straumann has just recently announced the release of their ceramic implant monobody, also a one-piece design, and it's, as far as an implant, very similar to what we have with CeraRoot and Z system. Again, a one-piece design that is compatible with the other Straumann instrumentarium. This implant is approved for use in Europe, and it's I think it's shortly coming to Canada and to the US. With at this point a little bit of research behind it. I think Straumann has about 18 to 24 months of data on these implants. Oral Iceberg has had also over 10 years of data with the CeraRoot, and the same goes with Z system with the iteration of the new surfaces. I mean, data is always coming, and we're having more and more studies that are underway showing us excellent success rates with these materials. So I'm going to focus in a little bit about the CeraRoot system. We have, unlike every other titanium system out there that is diameter based, which means that you put the largest diameter that the bone can accept. If you only have enough space for a 3mm implant, that's what you put in. If you're replacing a molar and you can put a 6mm implant, we choose that. With CeraRoot, we're a little bit different because our aim is not to put an implant. Our aim is to replace a tooth. So we replace a tooth with a tooth. We have 5 different shapes. The CeraRoot 1-2 is there to replace a lateral incisor or a lower incisor. CeraRoot 21 is there for a central incisor or a canine, upper or lower. CeraRoot 11 for a larger central incisor, a larger canine. CeraRoot 14 is an interesting type of implant. It's unique in that the platform is oval, and it's there to replace a bicuspid. And then we have the CeraRoot 16, which is the molar replacement. Each one of these implants comes in either 10, 12, or 14 millimeters, with the exception of CeraRoot 14, which also comes in an 8mm length, which comes in handy at times over the mental foramen. So these are the 5 basic shapes for the implants. We'll go into a little bit more detail in terms of sizing of each one of these implants. The Serroot 1-2 has an apex of 4.1 millimeters, and it's a straight wall implant. And you can see that the coronal portion or preparation looks like the preparation of a lateral incisor. So it's a crown prep. It's a tooth that comes in with a built-in custom abutment on it. And it's just wonderful. Once we get to the cases, we'll see how beautiful these things are. The Serroot 21 is 4.1 millimeters at the apex with a rounded apex again, and 4.8 at the most coronal thread, with the platform of the emergence profile coming out to about 6 millimeters. And you'll see that the portion that is actually in soft tissue has a dimension of 2.8 millimeters. In an ideal case, this is your biologic width or your soft tissue attachment. The abutment in this case is 5 millimeters, and it's very much like a preparation of a tooth with a lot of retention for the central incisor. Serroot 11 is the larger central incisor or canine, 4.8 at the apex, 6 millimeters at the crest, at the last thread, and a 6.5 millimeter platform. And again, this is for use with the larger teeth, as well as use with sometimes a smaller molar, or there are other indications for this implant. We are not too worried in the front with something that's very wide, because again, we don't have the connection. With titanium, that connection is a problem when we have to build in the profile, we have to add abutments. When we don't have a connection, the leeway of what we can do with these implants is much greater. Angulation is an issue for some clinicians. If we're placing these implants in sites that are augmented or sites that are ideal, angulation is really a non-issue. If we're a little bit off, just like a tooth, we can always prepare it. But angulation is very, very seldomly a prosthetic issue. Serroot 14 is again the unique implant, 3.5 millimeters at the apex, a little bit of thread that grabs the bone coronally, and then we have the abutment or the emergence, which is 5 by 7 millimeters. This implant, as you can imagine, is not threaded into place. It is a press-fit implant. Once it's tapped into position, those threads hold on to the bone and give you a great deal of stability inside the bone. The short, though very retentive abutment also means that this is the implant that I use for multi-unit cases. And again, once we get to the cases, we'll be able to go through that. This is our molar implant. Again, 4.8 millimeters at the apex, going up to 6.5 millimeters at the most coronal thread, and a platform that's 8 millimeters. Again, this is a very large implant, very nicely used in an immediate extraction socket, fills in the socket, a lot of stability. You can reach a high degree of torque with these implants in an extraction or an immediate case. The surgical kit is very basic. I'm not going to go into too much detail about that, only to say that the tooling with this system exists in either steel or ceramic drills and tools. The advantage of ceramic drills in my hands is that drills are much sharper, and they stay sharper for longer. Very nice to use these, and they stay cooler than the steel does, as ceramic is not a conductor of heat, it's an insulator, so you get a lot less heat from using these drills. The next portion is going to show a surgical protocol with a video, and we're going to go through a case. Again, it's going to be a left central incisor, which is the easiest tooth for us to film. And we'll go through the complete surgical protocol on this. So we have here the tooth that we're going to be atraumatically extracting. The atraumatic extraction, again, is important in everything that we do. We want to make sure that we don't injure the buccal plate. I'm going to check here for integrity of that buccal plate, which is of utmost importance to everything that we do. And we find that it is indeed intact. We use the Essex guide to give us the inclination of the implant, and these are the ceramic drills that we're using here. The 2.8 millimeter twist drill, and this is once you're using this this guide, you know exactly where you need to be. It simplifies the drilling process. Of course, you can use CT generated or any other generated guide to do these types of surgeries for an immediate extraction. When we know we have nice bone, this is more than sufficient. And we're done with the 3.5 millimeter, and we're going to now advance to the countersink and give us the emergence profile of the tooth. And at this point, we're essentially done with the osteotomy, and we're ready to introduce the implant into place. Again, we have the silicone carrier that's used to initially thread the implant. At some point, once we reach a certain torque, it bottoms out, and we switch to the torque wrench. And we're at this stage, we're advancing the implant. We want the restorative margin to be at the gingival level or slightly subgingival in these anterior cases. You're thinking about this just like where you would want to put the crown margins. You're not thinking putting what it is against the bone, because the whole surface of the implant is going to integrate. We just want to know that our restorative margins are where they need to be. And you can see enough palatal clearance for the restorative material as well. We're going to now show the facial clearance to show that there are no angulation issues with this. So see, with the probe carried against the other teeth, we have enough clearance for forced non-facial. And with the Essex appliance in place. We fill up the Essex appliance with some composite, and this is our provisional. And this is what the patient heals with until we're ready to load the implant. So at 3 months, this is what our healing looks like, with very minimal, if any, bone changes around that implant. The Essex appliance, the soft tissue healing, quite remarkable, that downgrowth of tissue. We have to actually remove some of that facial tissue to get an aesthetic crown. That's what we're doing to expose the margins of the implant and take an impression. This is with the crown in place, and you can see beautiful gingiva around the crown at 2 years with great stability. This is another case. Here we have a right central incisor. Again, an endodontic failure. And we proceed to an atraumatic extraction of this tooth. And we're going to see the vertical fracture on the facial of that tooth. We're checking the socket, and in this case, we indeed found small dehiscence on the facial. We prepare our osteotomy and introduce a CeraRoot 11 implant, and we're going to notice that we had a large defect in hindsight. And again, I treat this all these cases as learning opportunities. So we are a little bit of the pioneers in this, and we want to see what are the advantages and disadvantages. This would be not a disadvantage of the implant. This would be just the selection of a wrong implant in the hands of the surgeon. A CeraRoot 21 would have been a much better choice here, but this gentleman had large teeth, and the surgeon myself thought a larger implant would be beneficial here. This is what we ran into, a large defect where we compromised the buccal plate. I subsequently grafted this case and prayed to the implant gods to give us a nice, fun result. This is what the case looked like sutured. You can see the position of the implant. It's somewhat facial. But again, the platform, the emergence was really nice compared to the tooth beside it. In my head, I was thinking that the CERU 21 would have been maybe a little bit too narrow. But again, hindsight, it possibly would have been a better choice. This is what the case looked like sutured with the provisional in place. And 2 weeks of healing, we can see how the soft tissue has migrated up. And that was expected after what we saw, but we're going to allow this to heal a little bit more. And at 5 months, we have very nice soft tissue with the margin of the implant being prepared in this case to try and bring it more apically for aesthetic reasons. So we prepared that, took an impression, and we're going to fabricate a temporary restoration. And this sat with temporary restoration for a long time. It's yet to be restored, but we have a lot of stability with that facial tissue. Now, if we take this similar case, and this was perhaps a little mismanaged in terms of treatment planning, but something very similar, if it would have happened with titanium, there is no recourse from something like this. We would have had probably dark lines in the tissue. We would have had much more tissue recession once we connected the abutment. This would have been very unfavorable. With this ceramic, we had a little bit of help from higher powers in terms of our final results. This is the final radiographs. This is again before definitive restoration. This is a case of a missing right canine, tooth number 1-3, and this was treated in a transmucosal approach, flapless, and the placement of a CERU 14 implant. And the image to the right is immediately post-operatively. You can see how beautiful that oblong shape of the implant is. And again, you can see that from the facial aspect. We have plenty of restorative space, absolutely no need to prepare this abutment. This is a radiograph in place, and we simply take an impression 3 months after, and we're able to cement a beautiful crown for the patient and have a fantastic result that was really, really simple to achieve. Can we achieve the same with titanium in a case like this? Absolutely. We would have needed to sculpt some of the tissue, maybe push some tissue mesially and distally to get something of a papilla. We would have had to work really hard, whereas here we simply put a prep tooth in and took an impression. This is another similar case where we placed a CERU 14 to replace a lower premolar. This is what it looked like healed, and you can see the quality of the soft tissue around that implant is impeccable. And we're able to achieve the contours. These cases I restore using an iTero scan, and this demonstrates sort of the ideal positioning of that abutment. Again, no preparation was done here, no angulation issues, and we have more than enough restorative space in order to give us in the lab enough room to create a beautiful crown. You can see a little bit of the white on that crown. You can see a little bit of the implant, but the patient is just not going to say anything about that. We're never going to hear about, oh doc, you left a little bit of white in my mouth. The recession around the other teeth is yellow. And in fact, some of the patients come back and ask for the same white or the same whitening on the roots of the other teeth. It's not, even if we do get a little bit of recession around these implants and we see a little bit of white, if that is what the future is holding for me in 10 or 15 years, I'm not going to lose sleep over that. Whereas if I have the same issue with, let's say, a one-piece titanium, which is not used, but a two-piece implant, if we start seeing some of the metal, it is something that's difficult to deal with. Yes, we have connective tissue grafts. Yes, we have alloderm. But I would want a system that gives me the ability of avoiding these issues long term. And this is our beautiful result with a beautiful soft tissue. Our next case is replacing a left lateral incisor that has been missing for quite some time, and the patient has been walking around with a flipper. There's a defect, but we found that this defect was mostly soft tissue. The bone was actually there. So we proceeded with the radiograph, which again, the site was grafted previously, so that's why we had really no bone missing at all. This was the beginnings of the osteotomy and the insertion of a Ceraroot 1-2 implant. This was the image of everything flapped and closed and the implant in place with the final position of that implant. Now, in this case, because we had great stability and we had a great patient, we decided to immediately load or temporize this implant. And we created this provisional out of acrylic, and the patient left with that. Obviously, this was out of occlusion, no lateral contact, and with strict instructions for the patient not to load this. This was what the case came back at 3 months. We can see that our flap design allowed me to move some of the keratinized tissue buccally and try to compensate for that initial soft tissue defect. This, on some patients, heals great in about 3-4 months, and on other patients like her, it took much longer, so we see the scarring still evident at the 3-month mark. This is comparing the radiographs before surgery, at surgery, and 3 months of healing. Again, very, very little bone remodeling, if any. The iTero scan for that crown, I did not do any tissue conditioning. At 3 months, we simply scanned, we exposed a little bit of the abutment, and we scanned it. Our lab created a beautiful Emax crown, and this is the follow-up at 1 year. We still see perhaps a little bit of that scarring from the flap design. However, we have very, very nice and healthy soft tissue. We can see the quality of the papilla that we got proximally, and this is again without any intervention. All we did was we placed the implant. We had a flap design that would give us a little bit of extra soft tissue on the facial, but we essentially did this very simply and with a result that was above average. This is a case that's going to demonstrate the molar implant. We have a failed endodontic treatment, and the tooth was removed. Implant was placed immediately. This was the radiograph after 3 months of healing, and this is the view of the implant healed with some of the soft tissue overgrowing some of the margins. And again, you can see how beautiful that soft tissue is. We used the laser to expose a little bit of that margin, and this is our final restoration. And again, nothing was prepped. We simply took an impression, had a crown made, and cemented the crown in place. And in this case, this is full contour zirconia. And you can see the amount of recession on this patient. With a history of recession, I'm much more comfortable putting something that's white in that site. This is a case of the replacement of anterior 4 incisors, periodontally involved teeth, which were destined to be extracted. The 4 teeth were removed, and immediate CeraRoot 14s were placed. Whenever we have a bridge or multi-unit restorations, my preference is to use the CeraRoot 14 because angulation, sometimes when you have multi-units, could become a problem when you have a larger abutment. But the length of this abutment is very short and allows us to compensate for any angulation issues in the prosthetic steps. So this is the day of surgery, teeth extracted, we have the implants in place. These are the implants healed, and we ran into a problem. The positioning of our implants was such that we were too close to the midline, so we had a decision to make. Are we going to put 3 teeth on this and have perhaps a more stable periodontal prognosis, easier to clean, easier to maintain, easier for the laboratory to fabricate the file prosthesis, or are we going to do 4 teeth and try to design around these abutments? I utilized a piece of software called Smile Designer Pro, and it's an iPad software. It's really neat to treatment plan and have the patient involved in the planning. And in this case, even though the 3 teeth I think would have been periodontally perhaps more maintainable, the patient opted for the 4-tooth solution, and we obliged. This was our final zirconia restoration. Patient was still able to floss underneath, although this is a significant cantilever, and it's going to require much more maintenance than the 3-tooth approach. But this was what the patient wanted, and this was a little bit of a compromised result. So again, as with any implant out there, we want to choose our cases wisely. We push the limits sometimes with certain materials, but there is no single implant that can solve all of our problems. We have to be cognizant to that. And although sometimes we're able to push the envelope a little bit, we always have to be careful. We always have to keep the biology and at the same time the limitations of all these materials. And this was the final outcome of the case. Patient was very happy. We were very happy with the final result. We know that this is going to be stable, and periodontally we're maintaining and we're really watching this case. This case is again going back to endodontic failure of these 4 incisors. This lady came in complaining about the dark margins around these PFM crowns with definite oxidation damage. So the tissue is inflamed, the tissue is almost purple. Part of it is inflammation, part of it is the color of these actual roots. And everything was obviously splintered together, so we couldn't clean, decay, what have you, with the failures. Our treatment plan was the extraction of those 4 incisors and the placement of 2 CeraRoot 21s in the central incisor sites, and then creating a 4-unit bridge with cantilevered laterals, giving us the aesthetic result. The reason that we do a bridge that's formed like this, as opposed to the classic 2 implants in the lateral incisor areas, is strength. We like to have more bulk of zirconia in our abutments. The lateral abutment is much thinner, and it could probably withstand the force of 4 teeth. But when we have an alternative to that, when we can do this on 2 heftier implants, why the risk? And this is our philosophy. Our philosophy is to try to minimize the risk wherever we can and give the patients the most aesthetic results possible. And there is no, because we're using a one-piece design, we're not scared to put 2 adjacent implants in. It's not the same fears as 2 4mm titanium implants. In this case, it would be very, very difficult to get an ideal result. Whereas with these materials, our options are much greater. So this is at the time of surgery. Implants are placed. We did a little bit of socket grafting on the two laterals. This is a day after surgery. This is what everything looks like healing. Again, the patient leaves with everything protected with a removable Essex appliance with a little bit of the composite on the facial. As healing progresses, we can see the tissues around these two implants are still very nicely maintained. We can see the papilla is still maintained between, and you can see that the lateral incisors, those pontics are starting to take shape. This is a close-up view of the tissue as it's healing, and the surface of the implant starting to collect a little bit of plaque. An occlusal view of the healing, and again, we're waiting for the tissues to fully mature. The angulation, without an issue. This you can see with a more distant implant against that canine. You can see that we have more than enough space for our restorative materials. With a this is not it's a rather inclined maxilla, and we still don't have angulation issues. So the one-piece design is extremely, you have a lot of options in terms of restorative protocols, in terms of restorative flexibility, even though you have a one-piece design. This is replacing a tooth. If you had further resorption that was more palatal and you needed sort of cantilevered pontics, cantilevering facially, and you would have to have screw holes. You could do all these things with titanium, but you're doing it as a compromise to having an ideal bridge. With these implants, you need to have an ideal foundation before moving forward with reconstruction. But if we think about it, this is where we want to be with titanium. We don't want to compromise. We don't want to put the implant in where the bone is. We want to build the bone. We want to idealize the site before we go in there and place the implant, because that's going to give us the long-term success. And this is, at the same time, this is the reason why in the right cases, if our case selection is correct, angulation is not something I worry about. This is once we're through the integrative period, we're able to provide our patients with a fixed provisional. So this is our fixed acrylic provisional in place, and we're allowing the tissues again to mature. In this case, because we're not restoring a single tooth, we are going through some tissue conditioning with the acrylic to give us some ovate pontics, to try to mature the papilla between these teeth. We're ready for the impressions. We prepped a little bit of the implant surface, and we're also preparing veneers on the canine teeth. And this is our final restoration in place. Again, we have a 4-unit prosthesis in the front and individual canine veneers. And this is the post-operative radiograph. Very little remodeling of the bone. We have great emergence from the soft tissue. All in all, we have a really good-looking, stable restoration. And again, this is a close-up PA showing very minimal remodeling, and comparing where we started to where we ended up. We have a very, very happy patient. From a metal reconstruction with PFMs to a metal-free, long-term, lasting rehabilitation. The next case is what looks like a non-ideal site because we have no keratinized tissue on the facial. These cases, we advance the flap facially and place the implant, suture the keratinized tissue against the facial aspect of the implant, and we have Nice result 3 months postoperatively with a nice band of keratinized tissue. We have a little bit of the implant that's exposed on distal, but again, we don't worry about that because we want our margins, especially in a periodontically compromised patient or in an area where hygiene may be difficult, we want our margins to be super gingival. This is a CERA crown being used to take the impression, and this is our final restoration. Beautifully integrated with, again, a nice band of the keratinized tissue. The only downside is that we relocated the amalgam tattoo, and the patient complained that we gave them cancer at that site. But that's something that wasn't there at the beginning, but if you remember correctly, the amalgam tattoos were all on the crest and we moved them over. That's the only fault of this case, but otherwise we have a very nicely integrated prosthesis at 2.5 years with very stable bone. This last case I'm going to share with you is a more advanced case in a periodontally compromised patient. We are able to rebuild arches. We need a good solid foundation of bone, and this again goes back to what cases are indicated for ceramic implants. Something like this where we have failing dentition, or we have adequate bony structures, we can rehabilitate using multiple ceramic implants. This was the case again, preoperatively and correctly treatment plan. This is what we can look like. The exposed implant surface, or the white margins, could have easily been prepped and could easily have integrated a more quote-unquote aesthetic prosthesis, but this patient really didn't care. They came in with teeth that looked like the previous slide, and periodontally we know that there is no better stability than keeping these margins in a more cleansable area. This patient came in with periodontal issues. We want him to leave with something that is much more maintainable than putting a margin subgingivally. And it is our findings that there's much more health, much more ability to maintain these restorations long term when you're able to keep the margins in a place where the patient can clean them. This is the preoperative view, and again, we did this on 6 CeraRoot 14 implants with a single cantilever on the ends, cantilever that's not being loaded, and these are 2 separate bridges. I do some training for CeraRoot, and the training is available both in Canada, the US, and Europe. The system is, there's a learning curve to everything, and there's a small learning curve to this as well. The training encompasses 2 days of theoretical, some live surgery, and there's a lot of mentorship and treatment planning help available. So I urge you to have a look at this. These are exciting times in implant dentistry, and the options out there are numerous as to the implant systems and everything else, but what we give our patients, or we can provide our patients with, our solutions that carry less long-term problems with titanium. I'll be the first to admit that I'd love to solve these problems with titanium. My practice for a long time has been based on 2-piece implants and the services accompanied with them. But slowly we're transitioning to being almost completely metal-free, and we're seeing a lot less of these complications coming back, even though we loved playing with the components, with the titanium implants before. I welcome any questions on the forum, and we'll answer them as they come in. If you have questions and you want to contact me personally, my email is right there as well. Hope you enjoyed this. Hope you learned something, and we'll see you again on the forum.